Today's episode is brought to you by the Nuance Dragon Ambient Experience, or DAX for short. This is AI-powered ambient technology that helps physicians be more efficient and reduce clinical documentation burden. This is awesome technology. To learn more about how DAX Copilot can help reduce burnout and restore the joy of practicing medicine, ophthalmology, and other areas of medicine as well, visit nuance.com/discover DAX. That's nuance.com/discover DAX. Knock, knock. Hi. Hello, everyone. Welcome to Knock, Knock, I with Dr. Glockenflecken. That's me. I'm your host for this whirlwind adventure in the world of eyeball infectious diseases today. This is, people have been asking for this episode. We're going to be talking about herpes simplex keratitis, retinitis, uveitis, herpes simplex virus diseases that affect the eye. And so we're going to get to that in a second. Very, very exciting. If you've ever wanted to know how herpes can affect the eyeball, this is where you want to be right now, nowhere else. But before we get to that, let's talk a little bit about my recent call. I had 3 times a year. I know. All of you who take a lot of call are going to roll your eyes. Incredibly difficult. Just don't sprain them if you can avoid it. I 3 times a year, I take 1 week of call. It's part of the perk of being in the practice I am. I that was one thing that drew me into it, because I know is, no one really enjoys taking call. I mean, actually, I won't say that. Sometimes it is very rewarding to take call, but there's not a lot of enjoyment to it because, you're working after hours, you're missing dinner with your family, you're going in late in the evening and sometimes in the middle of the night, God forbid. And so it's not a fun experience, but which is why I was very excited whenever I interviewed at the practice that I'm currently at. And it was like, 3, maybe 4 weeks of call per year. I was like, great. I just finished residency where I was on call every 4th night. This sounds awesome. And so that's the big difference, really, one of the big differences between training and being out in practice. And when you're in residency, so I did residency at the University of Iowa, big level 1 trauma center. Everything eye related goes to the residents. You're learning. You need to see as many patients as you possibly can, just to see all the different situations you can find yourself in, so that whenever you leave training and you're in your job, you are ready. You're ready to take on whatever comes your way. So in residency, it's very busy call, and it's home call. So you're like constantly going back and forth. Commonly I would be up all night seeing, trauma patients that come in, orbital fractures, open globes, whatever it is, along with all the other stuff that comes in. So once I started this job, I was very happy to only have to do 3 weeks of call per year. And so I just had one of those weeks, and I thought I'd just tell you how it went. So my call, I take call for all of our practice's patients. And so if they have a problem, maybe they've had surgery or they're having some kind of eye symptom and they want to get some advice, they can call our office, and it reaches me through the answering service, and I give them a call. And then we also cover 4 community hospitals. So these are not level 1 trauma centers. These are not university hospitals. These are smaller hospitals, a little bit away from the metro, on the outskirts of the metro area. And one thing about this, you might think, well, that sounds really busy. 4 hospitals. That's a lot of hospitals. But the thing is, it's different than like taking a residency call at a university medical center. When you're out in the community, these hospitals, the emergency physicians, all of the physicians at these hospitals, they take care of things themselves. They do a lot. They're very knowledgeable, and that if they're giving you a call, it's like, seriously, they need help. They've encountered something that's beyond their area of expertise. Sometimes in residency, it's just, hey, let's call the resident because we got 1,000 other things to do, and it's a resident. Like, they need education, they need experience. You don't get those types of calls out in the community, all right? Because emergency physicians, like, they know how to take care of a lot of the common eye problems that come up. So I give them a lot of credit for making my call very manageable every time I have to do it. That being said, I still hate it. It's call. I don't want to go in the middle of the night. But I'll tell you how it went. It was actually very, very straightforward. Very, I can say that now, and avoiding any superstition backlash. But it was a very easy call. I did have to go in twice. So the first time I went in, it was in the evening, so not in the middle of the night, and it was for a patient who had an eye trauma, had a one of those fire pit rocks explode. Did you know that those can explode? This was news to me. I had no idea this happens. So apparently these rocks can, especially in a place like Portland or the Pacific Northwest where it rains all the time, they can absorb moisture, and then if you light up those rocks, you heat them up, they can explode, which is why I'm telling you right now. You're How about one of your eyeball tips of the week. Always wear safety glasses when around a fire pit. You don't really have to do that, but be aware that this is a possibility, that those fire pit rocks that you see in, like, every fire pit, they can explode. And of course, when things tend to explode, while you're looking at them, they tend to find the eyeball. Now, fortunately, this patient was okay, but most of the time when I come in, traumas are hard, because sometimes the eye's really swollen. It's difficult to get a look at the eye to make sure everything's healthy and there's no open globe injury. Sometimes the the imaging, the CT scan, which every patient will get when they have facial trauma, sometimes it's inconclusive. You can't really know if there's either a foreign body there or it's an open globe or something more serious. So most of the time, if I'm coming in, I'd say the vast majority of the cases are trauma cases. So basically, I came in just because I was concerned enough. I wanted to the emergency physician was pretty confident in saying that they don't think there's an open globe. But sometimes in those cases, I need to convince myself, and it is also very reassuring to the patient, especially and the family, in cases of trauma, to have an eye doctor say, "Okay, your eye is okay." Like, that's extremely reassuring, as you can imagine, right? So I went in, I took a look at everything, and the eye was totally fine. So it ended up, I didn't have to do anything, thank goodness. And it really wasn't that much of an inconvenience to me, because but I would have done it anyway at whatever time. So that was the first time I went into the community hospital. And then another one, I actually went in. This is like the first time I've done this in a while. I went in to see a patient that had a corneal metallic foreign body, like metal grinding, that kind of thing. Um, Normally, those aren't like pants patients. I don't have to come in to see those. But this is very fortuitous because it was on the weekend. It was like a Saturday afternoon, and I was already downtown Portland, just running errands, doing things, and the hospital paged me like while I was like 3 blocks away. So I was like, well, let's do it. Let's get it done. Also, I didn't want to um, make this patient like wait, you know, 48 hours, sometimes 72 hours with a metallic foreign body on the cornea, because that can cause lots of inflammation and stuff. So I just went right in. They were amazed with how fast I got there, by the way. I don't know if they were, there's three things that they could have been impressed by. One is I'm very well known in the emergency medicine community. They've seen all my videos, they see the costumes. And so a lot of times I'll get like, like a double take, like, whoa, oh, you're the guy, you're the TikTok guy, you're the doctor on TikTok. I'm like, yeah, yeah. So I usually do get recognized. And so maybe they were surprised by that, or maybe they were just surprised that they were able to get an ophthalmologist into the emergency department within like 15 minutes. I don't know. One of the two, probably equal parts surprise. Anyway, and everything went great. I actually taught the emergency physician how to my method of removing a corneal foreign body. I just have a little tool I use that I just can dig it out. But I think I've talked about that on this podcast before. But anyway, so that was the other time. And other than that, not a lot of phone calls. Pretty straightforward. Yeah, it's a good call. And it's when I say that there's like some satisfaction in doing call, I don't particularly enjoy it, but it is the patients that you see in the hospital, in the emergency department, everyone gets, of course, they get very concerned when something's going on with their eye. And so it's just a very rewarding experience to go in and be able to either treat or reassure someone that they're not going blind, that their eye's okay. And so that's the part of call I like. Like that makes you feel good, right? Like you really did help this person, either just help them feel better, allay their fears, or you did a procedure or surgery or something to save their vision. So it's just that can be very rewarding. The timing, not so much, but that's okay. That's what happens. That's part of taking call. All right. So let's get to our case of herpes simplex virus infection of the eye. All right. So let's take a quick break. I'll be right back. All right, here we go. Hope you're ready for this. You're on your commute. You're listening on your lunch break. Whenever, actually, don't do it on your lunch break. You don't want to listen to stuff about herpes while you're eating. Maybe you do. Especially if you're a medical professional. Like, what does it matter? Like you're constantly doing gross, disgusting things. Like just you eat when you need to eat, right? All right. So I'll give you a little background about herpes. Whenever I see a patient and they have a herpetic infection, they have a herpes simplex infection, I'm always a little delicate in breaking this news to them and how I break the news to them, because nobody likes to hear that they have herpes. There's kind of a thing with herpes that scares people. And so I'm very quick, like immediately quick, to distinguish that this is not the kind of herpes you get in your genitals. This is not genital herpes. That's herpes simplex virus 2. The second one. This is the first one. This one does not come. I don't know I think you can get it from like oral sex, but generally the virus, this herpes simplex virus 2 does not affect the mouth, the lips, the nose, the eye. This is all herpes simplex virus 1, the vast majority of which is not contracted or transmitted through sexual activity. Herpes simplex is the most common cause of infectious blindness. All right. In the I think that's the world. No, actually, no, that would just be the United States. Most common cause of infectious blindness in the US. Herpes 1 is much more common than herpes 2 because we see it all the time. In fact, the seropositivity, that means that you have antibodies to something. The seropositivity, you have antibodies to HSV. 25% of us by age 4. 25% of us by age 4. Now, the vast majority of those are asymptomatic, subclinical. You don't have any symptoms. You just get the virus somewhere. You get it off a surface, your parents, whatever, and everybody's kissing babies. And so you develop an antibody to the virus at a very early age. 25% of us, that's the case. By the age of 60, 100% of us, all of us, we all have antibodies to HSV1. So that just shows you just how common this is. It's not a rare thing, right? Which is why we see so much of this in the clinic. Right? This is not rare. The question is, does it manifest as symptoms, as disease? So what'll happen is you'll get the virus. And whenever you have like a primary infection of HSV, it can, I'd say probably the most common way this manifests is as like a lip lesion, right? A cold sore is what we call it. That's herpes. Congratulations, you have herpes. And kissing is a very common way that people get it, but it can be transmitted through. Usually it's through saliva or something. you picked it up on your hands and you rubbed your face, your mouth, so but most of the time it's got to be through it's direct contact with the virus. It's not like aerosolized or something. And so this actually brings me to my real don't do that eyeball tip of the week. Don't kiss anybody with a mouth sore. A lot of times people may not know you have a mouth sore. So if you have a mouth sore, don't kiss anybody. That's a corollary to the don't do that eyeball tip of the week. Just to keep your mouth to yourself if you got a nice juicy sore in there. That's a pretty common, primary infection. You get a cold sore or something like that, and then it resolves, and you think, oh, you're fine, and you are. But that virus, it lives dormant in your body, in your nerves, and it can be reactivated. It's a latent virus. It lives in if we're talking about the eye and this area around the eye. We're talking about the trigeminal ganglion, which is just a collection of nerves, all right, that supplies different things around the eye. And so a lot of the herpes we see is a recurrent herpes infection. That virus has laid dormant. Remember, 25% of us by age 4, 60% of us, 100% of us by 60 have this have dormant virus. All right, because we have the antibodies to it, so we know we've been exposed to it, and then it comes out. So the types of infections that we see, and herpes this is one thing that makes it's very challenging. This is a challenging diagnosis at times because herpes can look like a lot of different things. You can get your classic like sores on the eyelid. You can get dendritic lesions. This is basically like this branching pattern on the cornea that you put a little dye on the surface of the eye and it kind of lights up. It can manifest as kind of just swelling of the cornea, that front clear covering of the eye. Or it can just look like inflammation inside the eye. Or you can get necrosis of your retina, the back of the eye. So it can affect every part of the eye can be affected by herpes, which actually makes it kind of challenging to diagnose. So anytime we see something that kind of looks infectious, we're not quite sure. But it's a little weird. It's not like your classic like corneal ulcer from contact lens wear. It looks a little different. Something we don't see all the time. We immediately will think, could this be herpes? It's like just a reoccurring loop in our brain. Anytime we see an eye infection, could this be herpes? Most of the time, nah, this isn't herpes. It's conjunctivitis. It's a corneal ulcer from contact lens wear. It's not HSV. But sometimes we ask ourselves that question, like, oh yeah, this kind of does look like herpes. When you see a dendrite, that's very classically herpes, that branching infection on the cornea. It's sometimes very pretty appearing. But sometimes it's not so easy. Sometimes you get just this corneal swelling. Sometimes you get these deep blood vessels that start growing into the cornea that can be seen in a variety of different diseases. And so it's one of these masquerading types of infections that it can be anything. Honestly, it could be maybe it's syphilis. Maybe it could be sometimes lymphoma. It's sometimes challenging, which is why I have a lot of respect for my cornea specialist colleagues, because in fact, this just happened a couple weeks ago. I had a patient had some interesting scarring in the cornea, wasn't sure what to make of it, sent it to my cornea specialist, like, oh, that's herpes. I was like, God, really? I should have known that. But I didn't. That was like the one time I didn't think, could this be herpes? And it turns out it was. So it is common enough, but it can appear in uncommon ways. I guess that's the point. So, but the typical symptoms that people will have with this disease is pain, especially like localized to the front of the eye, light sensitivity. That's a big one. Really, anytime you have like a cornea infection, you're going to get pretty light sensitive, which also could indicate that there's some inflammation inside the eye, what we call uveitis. Your eye is going to get really red. Typically with herpes infection, herpes simplex, it's going to be, or herpes zoster, which is another type of herpes virus that you see in shingles. It's unilateral. Now, it can be bilateral, but usually that requires the patient to be pretty immunocompromised for there to be bilateral involvement. So typically it's unilateral, and it's always the same eye, right? People can have, like I mentioned, recurrent herpes infections, but that's it often happens in the same eye. It doesn't usually kind of go back and forth, which is a clue, right? If I have someone that comes in with these weird findings, but it was in the other eye once and then this eye, it's probably not going to be herpes unless they have some kind of immunodeficiency. Um, let's see, what else? What other manifestations? I mentioned real quickly the retinal necrosis. That's a scary thing, and I've only seen that once, and it's absolutely devastating when you see that because that is most of those patients don't regain any vision. They have all kinds of complications, retinal detachments. They can go blind, but it is much less common than the typical manifestations of herpes in the eye, which is the dendrite lesions. You can also just get like a conjunctivitis. I'm telling you guys, it can look like a bunch of different things. So yeah, if you got a red, painful, angry eye, like go see either an optometrist or an ophthalmologist, or if you don't have an eye doctor, go to your primary care doctor and they'll find one for you. But it's people are pretty in quite a bit of pain. It's always going to be one eye, right? One eye. How do we treat it? So, what we do, especially for the most common forms of this, which is the corneal infection, we will prescribe an antibiotic. Now, the reason we do that is because if you have a surface corneal infection, what we call epithelial keratitis, epithelium, top layer, keratitis is how we say cornea because we got to always make things more complicated sounding. Epithelial keratitis, HSV, epithelial keratitis, that's the dendrites that I'm talking about. So if you have something like that, we always cover the patient with figuratively, not literally, with a topical antibiotic in order to prevent a secondary bacterial infection. Because that cornea is at risk for developing a bacterial infection when they have that viral active virus on the surface of the eye. We don't want that. That makes things so much more complicated. So we'll go ahead and cover them with a topical antibiotic, like ofloxacin is a very common example that I use. And then we treat with oral antivirals. Now, there are topical antivirals, and I see patients that come in who were treated in urgent care or anywhere else, and they were given a topical antiviral. There are studies. There was a classic study called the HEADS trial. I'm not going to go into it, but they use that's what they use. They use topical antiviral. It is extremely toxic to the eye. Patients don't tolerate it very well. And the oral antiviral medications like acyclovir, valacyclovir, they have excellent penetration to the cornea. They will treat the virus. So I never, except in rare, I can think of maybe one time that I've prescribed a topical antiviral in all the years I've been doing this. And the oral is the way to go. Oral is the way to go. So for HSV, you give 800 milligrams, 500, I can't imagine, 400 milligrams of acyclovir 5 times a day. You got to treat it pretty frequently. The reason valacyclovir is a little bit better, which is the brand name Valtrex, is because it's only 3 times a day. A little bit more expensive though. So we'll treat orally, and which takes care of it for the most part, and patients do very well. Now, if someone comes in, they've had multiple recurrences, like this virus, God damn, it just keeps coming back over and over again. They've had 3, 4, 5 recurrences. A lot of times we'll put them on prophylaxis. We'll just say, hey, take 2 pills of acyclovir every day, or 1 pill of valacyclovir. Because we know this thing's going to keep coming back unless we just keep it suppressed. And patients do fine with that. They've patients that have been on prophylaxis for years. And so that's how we treat it. Again, the topicals, they're just nasty. The big thing, one thing you don't ever do when you have active virus on the eye, those dendrites, you don't put steroid on it. It's like it's food for viruses. All right. It could blow it up, make it so much worse. So just avoid the steroid eye drops if you're a person that prescribes eye drops. What else? What else? What else? What else could you possibly know? I feel like most people are like, oh, thank God it's not a genital herpes thing. Like, no, you don't got to rub your eye on somebody's genitals to get this. It's not that kind of thing. People are very reassured actually that it doesn't mean they have like genital herpes. And so if I'm sure this episode is smooth sailing after some people learn that. Yeah, I think that just about does it. I think you guys have had enough. I've had enough about herpes. All right. So if you want to hear about other types of eye infections, I'm happy to oblige. I haven't done I haven't done an episode on like just straight up viral versus bacterial conjunctivitis. I guess I could do that. It's not the most interesting topic, mainly because I personally feel like bacterial conjunctivitis is disgusting, is like my least favorite thing to talk about and to see. It's just soupy eyes, and anything you can describe as soupy is not going to be a fun experience. So I could do that. I could do, I do need to do a syphilis episode, because syphilis is, in a lot of ways, it's one of these masqueraders. It's very similar to herpes in that it can look like a lot of different things. There's a lot to the herpes discussion we didn't go over because I didn't want to get too into the weeds, even though that's the point of this podcast. Knock Knock Eye is about getting into the weeds of eyeballs, but like low weeds, like contained weeds, not marshes and forests. We want to keep it. I want to keep you listening. All right, so. That's it for herpes. Let me know what you thought. Let me know if you have any suggestions. I just yesterday I was going through the comments, mostly on YouTube is when I see most of the comments here. So go on YouTube, comment. Let me know what kind of topics you want. I get all my ideas from you guys, hearing about you. Also, I have a Patreon. I get ideas from Patreon as well. So that's associated with the Knock Knock High. This is the whole podcast. Knock Knock High, Knock Knock High. You can check that out. Find all the information at glockenflecken.com. You can find information about our podcast and the Patreon. And just let me know what you want to hear about, what you're curious about with eyeballs. Thank you all for listening. I'm your host, Will Flannery, also known as Dr. Glockenflecken. Thanks to our executive producers, Aaron Corney, Rob Goldman, and Shanti Brook. Editor and engineers, Jason Portiza. Our music is by Omer Benzvi. Knock Knock Eye, Knock Knock Eye and Knock Knock High is a human content production. Take care, everyone.
Knock knock, goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.